Thanks, Steve. Welcome, everybody, here again. Yeah, so as Steve said, we're going to be looking at the anterior and sort of lateral hip today. You know, traditionally, this doesn't come into the department very often. The hip, we tend to get it either post-operatively, or if they come in, they're looking for either trochanteric bursa or gluteal tendinopathy, but it doesn't come in that often. I mean, people that are working in sports clinics, sports injury clinics, they'll probably see a lot more of these. So the first thing I'm going to do is to find the hip joint. So, and it's going into the crease of the groin there, and I'm looking for that rounded sort of femoral head there, and that's the image I'm going to find. Right, so I know where my hip joint is, and then I'm just basically going to just angle the probe so I can get the joint and the femoral neck. And then, so if you can see, so as I come down the femur here, you can see the yellow. This is the femoral neck here, and then obviously the shaft of the femur here. So this here is where you'll be looking for your effusion. There's the femoral head, and there's the joint space. And this will be the psoas tendon going across there. We're going across here, and then this is where you look for, you know, if there's any effusion or any osteophytes and osteoarthritis and things like that. You can see this nice smooth joint femoral head here, and then you can go, and this is the labrum here. Okay, so you speak on these sort of labral cysts or anything like that, you know, effusions, synovitis, and things like that. And I can look at the femoral head all the way around here. Look at the contour. Yeah, it's all very nice and smooth. And so obviously, it hasn't got an effusion, but you're looking for any sort of fluid layer here, and you measure it, and anything sort of above 7 millimeters, 7, 8 millimeters is, pathology for effusion. Okay, so that's a little bit of the anterior hip there. If I go slightly cephalad, I've got this bony prominence here, which is, oops, I'll just run that again. So we've got, this is the AIIS, so anterior inferior iliac spine, and this is where your rectus femoris will insert, and that is the rec fem tendon there. I think you're touching the screen as well, I'll be there.
Sorry, Dave.
No, you're okay. Focus. Okay, so I can follow that.
Okay, got the funny one.
Yeah, cool. Okay, so rec fem. Now that's obviously the direct head. There's an indirect head. This is going to challenge me now because it's quite difficult to get the indirect head. So basically, just go transverse on the inferior spine, and then I'll run over there, and then you come out lateral. Keep turning the probe, and you see, and I'm sort of digging in here and angling back towards the femur, and it's this structure here. Find the arrow going along here. It's a little bit anisotropic. It's there. So that is the indirect head going there. That's probably as good as you're going to get it. Ideally, if you straighten out the more you straighten out the probe, the better that tendon will be. There you go. So that's a little bit better there. Going across there, that's the indirect head. And then back. Sorry, you're right, Abid. I'm
fine.
Digging
just trying to keep a good picture for the guys.
Okay, so that's that bit there. Now you can obviously look for sort of snapping hip syndrome, which is just about here. So you've got the iliacus and the serous major here. And I won't do the manoeuvre, but you could do sort of sort of flexion and then external rotation and then down, and that'll basically what you're looking for is this tendon here to snap down onto this the ramus here. You can demonstrate that dynamically if they've got a snapping hip syndrome there. So let's go back to the rect fem, and we can follow that back out into the rectus femoris muscle belly, and then obviously you're just looking to interrogate the muscle belly. This is the central tendon here. So you're looking for tears along here, and this is the muscle belly. And then you can obviously follow that down. I'm going to strangle Abby if I take it any further. So that's
It was funny though, didn't it?
okay, and then obviously back up there. So those are the main things that I look for in the anterior hip. I may extend the exam depending on what the symptoms are, to look at the, look for inguinal hernias. I'll just go a little bit more settled out for that, but I won't do that. But you can essentially go a little bit higher and assess for the inguinal canal and inguinal hernias. I usually include that in the hip exam if it's necessary. Okay, so then I go and have a look at the lateral hip. So what we're going to do is we're going to turn Abby onto his side. There we go, and probably put a little bend in the knee. There we go. And essentially, I'd start on the femur, getting the femur in cross section. Alter your depth a little bit here. Okay. And I come up, keep coming up until I see this image here. So I'm looking for that sort of mountain, if you like. Let me just alter this bit. Okay, and this is your anterior facet, and this is your lateral facet. So this is where your gluteus minimus will be, and then obviously gluteus medius on there. So I'm just going to add a bit more gel. And it's quite tricky this, and this will be, you'll find this tricky in all but your very slimmest patients. So just bear in mind that this isn't going to look perfect on pretty much 90% of your people. So once you find that sort of that peak there, first thing to do is interrogate the gluteus minimus. So what I need to do is I need to basically come across here and I straighten up the probe. So I make that basically the anterior facet straight, horizontal like that. And then you angle this probe then back to this sort of ASIS, and that should be in the optimal plane. And then you can follow this out, and you need to angle down as you're going into the as it goes out into the gluteus medius. Let me try that again. Actually, hold on. So I need to increase my depth a little bit. Oops, the other way. So I'm going in transverse section now, so I'll see the muscle belly here first, because I'm in transverse, and then this is a bit of the tendon here. So this will be the gluteus minimus. Just move that down a little bit. Okay. And then back onto the transverse section. So that's the insertion there. So once you've found that plane, what we do then is just go 90 degrees to that, and that's the plane of your gluteus minimus in long section, and you can interrogate the insertion here, looking for any tendinopathy, tears, osteophytes. If you've got any sort of bony irregularities here, then look a little bit harder, because the chance goes up of finding a tear when you've got little osteophytes and cortical irregularity and things like that. Okay. So I go back to the peak, and now I want to look at the gluteus medius. So again, I flatten the curve there, so I'm basically over the transverse section of gluteus medius, which is quite broad here. So this is all gluteus medius in transverse. Okay, and then I can obviously go out into the muscle of glute med. And then back. And if you lose yourself, just find your peak again, go back, and then I'm on the lateral facet there. Okay, and then basically just turn 90 degrees on that, and there's your glute medius long section. And you're looking for this sort of feather-like appearance. And then any sort of osteophytes here will impinge here, and you can pick up little tears here from osteophytes.
To get the right angle.
Right, can you manage that?
I'm giving myself a shoulder impingement trying to get the right camera angle.
You're making everyone sick. I don't know about this.
It's not easy to image your own lateral thigh.
Okay. There we go. So losing weight, go back to the peak. There's minimus. There's medius. And if you go right at the back here, you should be able to pick up the posterior band, which are these fibers here. And it's the superior facet, posterior superior facet, and there, if I just angle back and up, that is the posterior band there of glute medius. So you check both bands, okay, and then you can go back into transverse and then back across. It's quite complicated to do. If you've not done it before, it's easy to. It's much easier to try and do it hands-on and then follow it with the anatomy. And you follow these peaks and troughs, and that allows you to get a picture in your mind. It's quite difficult to watch a screen on this and get the idea of what's happening. I've got a couple of PowerPoints I'll show you. Actually, let's show you those now. Lovely. Okay. Yeah. So this is what I'm talking about with the anterior hip. So looking at the femoral head and the acetabulum, and then that's where those two white arrows are. That's where you're looking for the effusion, and you measure, and you're measuring that sort of that blue area that's in the diagram there. And that's the measurement you take. Obviously, the top image isn't showing any fluid, but the bottom image is. Because the capsule is quite thick and it wraps back around on itself, so you mustn't include the capsule with that, just include the fluid. Now, what else have we got? A minute. There we go. So there's a little example there of one with a bit of fluid, and obviously the one on the left that's got a few osteophytes and a bit of cortical irregularity. So that's what you're looking for, and you'll see that quite easily. So this is essentially what I was trying to explain with the scanning. So you've got glute minimus anteriorly on the anterior facet here, and then obviously you've got glute medius on the lateral facet here. And if you angle towards the sort of ASIS, you should follow this quite easily with the ultrasound probe. And obviously, the skinnier the patient, the better and easier it becomes.
Do you get requests to look for glute med min tendinopathy?
No, it usually comes as
trot bursa,
and most of them end up being just tendinopathy of the glute tendons. You don't see that much trochanteric bursa, to be perfectly honest with you, unless they're sort of come post-op and they think they might have one. Okay. So there's that. That's probably a little bit of a better diagram to show you that peak I was trying to get. So you're looking for that peak here, okay? And obviously you go anterior for the glute min and posterior on the lateral facet for the glute medius. And obviously if you pick up these fluid areas, you've got the subglute minimum bursa and the subglute medius bursa. And then the trochanteric bursa is quite posterior. So you have to sort of go right round the back and try and pick that up. But I can show you a way to do that in a second. So if we go back now. So let's run through this again. So there's that peak that you saw in that diagram. You angle over, so you flatten that peak because you want to look at the glute minimus first. So I'm digging in and effectively moving the probe round to get a good anterior portion of that glute min. And then I'm angling longitudinally back towards the ASIS, and that gives me my glute minimus tendon insertion there. Okay, this over the top here is ITB, by the way, so you can interrogate the ITB at the top here, and you can get like exterior or external snapping hip. The other one's called internal with the psoas major. This is usually external snapping hip. So you can get the ITB snapping across this area when you do dynamic assessment. Yeah, I'll be showing you that now. So this is a good movement as well to get the plane of your bursa, because it gives you the if you look at that, there's two areas there moving away from each other in opposition, and this is your plane for your bursa, so you can pick up that nicely. So all you do is you go around the back here, following it round posteriorly. See if you can see any fluid collections bursa at the back here. It's quite a good way to see your different layers there. So you've got the ITB, glute min, glute medius, and transverse, and that's it in a long section. Okay. So this would be, let's go to this maximus, medius, minimus, ITB, and then tensor fasciolata. Okay. So that's pretty much the lateral hip. What I look at. So I interrogate the ITB as well. and you can follow that down and follow it up as well. So its insertion and the ASIS there. So you can see the layers quite nicely. Just trying to get that. So you might get a lot of this. You may lose this peak as you get more of the older generation. So you've got to really hunt for your sort of peaks and troughs to try and get your landmarks, because it gets more and more difficult. And they're thin and they're young, and they're it's quite easy to find. So practice on those to start with. But as they get older, all these little peaks and troughs they diminish and become irregular and things like that, and it becomes very difficult to do it. But you just have to sort of try and find your landmarks there. Okay.
Adrian, can the piriformis be seen?
Yes, you can see the piriformis, although I probably wouldn't use this probe. I'd probably use the abdominal probe, and I'd go sort of, at the butt of the buttock here and angle it back towards. So it becomes quite difficult with this probe because it's not as good to get down. But I'd probably tend to use an abdominal probe. But it's not something that would come to ultrasound, as I say. It would probably go to MRI, but it's one of these things that, you can, if you're lucky, you see it. If you're not, you don't. So, but yeah, it does. I don't think I've ever had a request come in to look for piriformis at all. But you can see it on ultrasound, but how valuable it is, I don't really know. So let's go back to the anterior hip, just go through that again. So again, if you can correlate that image to the one I've just shown you on the PowerPoint there, you can see there's literally, there's no effusion here, but you could probably measure one quite easily there if there was. Look for any osteophytes and things like that. Again, check the contour of the bony alignment there, which is really quite nice and smooth. And then you've got your rec fem there on the inferior iliac spine. So this this shadowing down here, get the arrow. This is probably your indirect tendon going down. Didn't show it very well there, but so you go transverse section, you follow it, you dig in that side of the probe, keep digging in, and then you're looking for that. Sorry, Abid.
Sorry.
Looking for that tendon there, going across there. Can't quite. You just see it there. It's a bit anisotropic, but it's going across there. Obviously, you'll struggle to see this on your big chunky athletes, but on there, that's the indirect head. And then back out to the rec fem muscle. So that's what I would do in an anterior lateral hip scenario. As I say, I might include the inguinal hernia. So there's several hernias. There's an indirect and a direct, but we'll just look at the indirect for now. So first thing you do is you find your rectus abdominis, which is this muscle here. And then what you're looking for is the inferior epigastric vessels, which on average are pretty non-existent. So here they are. They're coming here.
Sharing all my secrets with the world then.
Yeah. So here they are, just coming under the rectus abdominis.
No, they're proper.
Yeah, they come. And you follow them out. Keep following them out until you get to the vessels here, the iliac vessels, and that's roughly where the deep ring is. And then you get I say to average, right? So tighten your tummy muscles, and you get them to valsalva. And that looks like you might have a direct hernia here, possibly. Anyway.
You always find something.
Yeah.
Every single bloody week.
So this would be where the indirect is, where the inguinal canal is, and you follow that down. You can follow that down to the testis, but we're not going to do that. And the direct will be sort of medial to the inferior gastric arteries. So in this sort of region here, so you've got the rectus abdominis, you've got the inferior epigastrics, and the inguinal ligament is about here. So it'd be in this area here where it would protrude up, which I thought we saw a minute ago, but could be just a bit dull. And then so this, and then an indirect will come from lateral to medial. So it'll come over the inferior epigastrics down the canal. So if you see something coming that way, lateral to medial, that's an indirect. If it comes straight out, which is medial to the inferior epigastrics, that would be a direct hernia. And that's looking at the inguinal hernias. Obviously, you can get Spigelian hernias, which go up between the semilunaris here. And epigastric, which is a little bit higher, but that wouldn't be really related to the hip. So you can get, them come in with hip pain, and it'd be some like hip and groin pain, and it'd be like a hernia rather than the gluteal tendinopathy or anterior hip or whatever. So just bear that in mind. So that pretty much covers what we're going to look at today.
Got one or two requests coming in now. They're very well behaved, our guys. They're waiting to and now requests coming in. So can Adrian show us some notorious, the TFL abductors in the anterior?
So the sartorius is on the ASIS. If you just
and another request is the femoral nerve. Femoral nerve.
So that's the ASIS. So that's probably going to go down into this into the sartorius. I'm going to get crossover from thing here, but yeah, so you've got the ASIS there, following it down, and then I'm going to have to scoot through it. That's there. That's the sartorius there. You can tell because it's quite a small sort of muscle, but it's a long muscle that goes all the way down, and obviously goes down onto the medial aspect. Tension fascia lata is a bit further round. So probably more this area here. You follow that down. Oh, I can't see you.
Getting carried away.
As you come down to the lateral hip, it's probably it's this one here, just there. You take it upstairs. The femoral, is it the femoral nerve?
Yeah.
So I'll just come down into the groin here. This is the femoral nerve here, I think. So basically, when you get into the groin area, it sort of goes nerve, artery, vein, and it's going to be there. That's where I look at it. I mean, I wouldn't, unless they particularly ask for that, I wouldn't necessarily include it as part of the exam unless it was, indicated for that area. I mean, you can look at the lateral femoral cutaneous nerve, which is up by the ASIS again. Again, this is once in a blue moon they may ask you to look at this. It's really quite difficult to see. Yeah, so I think there's a bit of it here. Yeah.
That was the nerve, did you say? That was the from all.
What, Steve?
That was the nerve that was requested.
Yeah, lateral femoral cutaneous nerve, which again don't get asked very often, to be honest.
All right. Well, interestingly, back to the question you got earlier about the piriformis. Chris has made an interesting comment. Chris, a regular contributor. Nice to see you, Chris, as always. Hi, Adrian. As a physio who uses acupuncture with sports patients, I do image piriformis when using the big 4-inch acupuncture needle to ensure I am in the right place. That's interesting. What probe would you use, Chris? Okay, so it would be what you suggested.
The curves. Yeah.
Yeah.